My daughter was born with a genetic disorder called Cri-du-Chat. She has a trach and a G-tube and doesn't communicate. She doesn't walk or talk or eat anything by mouth. She's legally blind and deaf in one ear as well, so her care requires a lot of attention.
The pediatric specialty care vision is to provide the deepest complement of resources to this patient-resident population.
So we can provide that bridge between hospital and home that is so important.
There's many layers as far as it being special and unique.
They give these kids opportunities they would very unlikely have anywhere else.
Pediatric specialty care is wholly owned by post-acute partners. We provide post-acute services across the continuum of care, from pediatric care to geriatric care, from facility-based care to in-home care. What makes pediatric specialty care unique is because it's part of the larger post-acute partners family, we're able to bring an enormous amount of resources, financial resources and people resources, to each of these pediatric specialty care settings. And that is unique.
We're a robust, very acute model that has all kinds of care needs, where we're taking children directly out of NICUs and PICUs that are technology dependent as well as clinically complicated, that require a lot of physician services, and we're delivering those today. We, in our setting, can really throw the weight of resources behind a child's care, and we think that helps children get home sooner. We can bring therapy into the mix, whether it's PT, OT, or ST. We can bring our RN clinicians into the mix. We can bring our vast network of physicians, whether it's a pediatric pulmonologist, whether it's a neurologist, whether it's a cardiologist. We bring those all into the mix and bring them to bear on that very concentrated period when we're trying to work to get a child home.
The admissions team for pediatric specialty care is really important. They're pulling together all of the pieces when we get a referral, either from the hospital or the home or the rehab setting. We are coordinating all the aspects of the insurance approval. We're really guiding the family through the process, and the liaisons are really working on making sure all the medications are in place, delivering that to the nurses here internally, as well as any specialty equipment.
But she was admitted a few weeks ago for an ileus resolved, secondary urinary tract infection. Right.
PSCE plays a great deal of emphasis upon an interdisciplinary approach to the care of each particular child. Each child, upon his or her arrival, is looked at as an individual. We look at that particular individual's past medical history, his or her medication management, his or her immunization history, his or her family history, the family dynamics, and we put a care plan in place to address all those particular needs. If there's greater emphasis that's to be placed upon medication management, we channel our energy and thought process into that. If greater energy needs to be placed upon a social aspect, we channel our energy into that. And more often than not, it's an array of services that come together to allow this child to maximize his or her potential while they're with us and under our care.
This resident population has very special needs, and those needs are not currently being met in the typical settings where we find these children residing. Those needs include social needs, psychiatric needs, pharmaceutical needs, rehabilitation needs, education needs, nutritional needs, recreational needs. It's very difficult for the typical healthcare setting to provide all those needs under one roof. Our mission is to provide all those needs under one roof. And if we're successful, then these children will thrive.
Access to educational facilities, her special education teachers and her therapists was somewhat limited. Getting them to come out to our house was really difficult. And so here, the therapists and education is provided on site for her, and that's an advantage so that everything is consistent. She gets it regularly and has the same providers on a regular basis. So as far as her education and therapy goes, it's much more consistent.
Children that are referred to pediatric specialty care have a variety of complex medical needs. These needs can include tracheostomies, ventilator management, non-invasive and invasive management, wound care, IV therapy, TPN, enteral feeds. That's just to name a few.
A child who leaves the acute care center with a significant brain injury, some who has suffered some form of trauma, a child who has been living with a congenital disorder for years, very complex, a child with a complex congenital disorder who has a very difficult time feeding, or the inability to digest normal foods, or a child with some type of neurological injury secondary to a motor vehicle accident or fall, or intentional trauma. Multiple medications being used. We have some children at pediatric specialty care, for example, that have a very malformed intestinal tract. Either the intestinal tract is absolutely blocked, either parts of the intestinal tract are missing, or sometimes the intestinal tract is present outside of the body when that child is born. It is challenging, it is difficult. For the most part, we feed those children with different types of tubes that run into their stomach or other parts of their intestine. That is a challenging but very doable level of care that we provide at pediatric specialty care.
We are set. We collaborate with all the children's hospitals across the state. Our medical direction comes from these institutions with high expertise on caring for these medically complex children.
We have specialists from the region that tend to the needs of the children. Many of these specialists come right to the site. We actually have a dentist that comes and advises the staff on good dental care. You could imagine some of the concerns and needs these children have when they're not able to open their mouth adequately, when there's some facial deformity that potentially could prevent them from having good dental hygiene. Poor dental hygiene can lead to infection. And infection in this patient population can be absolutely critical and very detrimental. These children have very complex neurological disorders, have seizure disorders that are very difficult to control. So the neurologists, which we have available to us on site, is key to the safety and good health of these children at pediatric specialty care.
Doctors are on call 24/7, 365 days a year. We're only a phone call, email, or e-fax away. I check in daily in the morning upon awakening with the various sites. We talk during the noon hour, and we talk throughout the course of the day if any issues should arise. Because we all work as a team, anyone on the team can be reached at any time to address the needs of that particular child. So care plans can be augmented and treatment strategies can be put in place.
And medications are passed with an electronic medical record system that is interfaced with our pharmacy to allow for a smooth transition for reconciling medications, medication delivery, and accurate and timely medication passes. We do time-sensitive documentation, so as soon as a skilled need is being provided, the documentation can take place instantaneously on our remote laptop EMR systems.
I know what's going on at any time during the day because I have direct access to point-click care, which is the electronic medical record that we utilize. So if a physical therapist is working with a patient, and if I have concern about what's going on with that patient's range of motion or his or her ability to ambulate, I can literally be in my bed or at my kitchen table, pull up that particular individual's chart and see how he or she is progressing in physical therapy. I can take a look at his or her chart and see when he was last seen by physical medicine rehab. I can find out what their thoughts are, and we can augment the care plan accordingly.
Excellent. We do a lot of co-treatments between PT, OT, and speech therapy. One of the benefits is, for example, a child might be physically able to do sit-to-stand transfers, stand, pivot, sit transfers, and then are ready to do some of those transfers in the bathroom. So the occupational therapy and I will work together to do the stand pivot transfers to the toilet, and then OT would work on clothing management, hygiene, and ADLs. Another important thing for speech therapy is positioning. I might work with the speech therapist to get the patient in the proper position so that they're not slouching, their head is upright, or if they need a certain collar to keep their head up. All that co-treatment is very important. I'm able to go to the specialist appointments with the children, and I'm able to meet the physiatrists, the orthopedists, the ears, nose, and throat doctors even. I'm able to ask physical questions of how we can improve, a certain kind of bracing, or I might ask if we could try serial casting instead of surgery, or Botox injections instead of, something more invasive. Standers are a way to build strength in the legs of the children, to build strength in their bones. It helps circulation, digestion, respiration. A lot of the children have been able to wean off the ventilators from getting therapy here at PSC, where we strengthen their body, and in turn their lungs strengthen, and then they become stronger immune-wise, and then eventually are able to get off the ventilator. A lot of these kids, if they didn't get therapy, may not go home.
We have a complement of nursing, respiratory therapists, nurse aides on every shift, 24/7.
Respiratory therapist is an absolutely key member of the team, and it's a pediatric-trained respiratory therapist, which is very important.
We have pediatricians as well as pulmonologists on staff. The pulmonologist will address primarily the vent-dependent children, the trach children, and any issues that should arise with any of the other children in the patient population that is pulmonary-based.
Yeah. Good job.
Nutritional support is absolutely key. These children are working hard to stay alive. When you work hard to stay alive, you need to have maximum nutritional support, and we were able to do that at Pediatric Specialty Care.
So you have some more to eat? Yes. Yum.
Our team also comprises of social workers, program specialists, rehab services, administrators, DONs, and supervisors on every shift. The support staff all come together to complete and document the individual service plan.
All right.
The case mix of the population that we're serving does fluctuate, so the staffing models fluctuate as well. Typically, a nurse could have anywhere from 5 to 8 patients. A respiratory therapist might have 10 to 12 patients, and a nurse technician or a certified nursing assistant could have 10 to 12 patients. Depending on the acuity level of the child's individual needs, the acuity and the staffing model fluctuate accordingly.
Today we're going to go over how to change a G-tube.
We invest heavily in our recruitment and training of professionals. We spend an enormous amount of time and capital investing in their education and providing for them a career path so that they view pediatric specialty care as a career. As a result, they stay here for a long time, which provides consistency and continuity to the children and their families.
Having master's prepared social workers at Pediatric Specialty Care reflects the organization's value in having skilled and educated professionals working with families.
The clinical liaisons also will learn some of the care if needed. So maybe it's a specialty dressing or something that is specific to that patient that is not something normally done here. They'll go and learn that care and then bring that back to the team and educate them.
The anatomy and physiology of a 7-month-old is different from a 7-year-old versus an adult, where essentially our anatomy and physiology is all the same. But in those first 10 to 17 years of life, there's a constant change in the anatomy and physiology of children. The nurses and physical therapists and respiratory therapists are trained to appreciate those changes in the child's anatomy and physiology. The child who potentially has a seizure every 5 minutes or every 5 days, who cannot eat, cannot breathe by himself or herself, and cannot walk. So it requires a team of specialists that is able to support all the technology, especially the ventilator, especially the tracheostomy, make sure moment by moment that the secretions are cleared from the airway. When you're managing the secretions, the management of that secretions may set off a seizure. So in the middle of doing one thing, you're now responding to something else. And how do you deliver seizure medication if the child is not taking it by mouth? You have to deliver it through a tube that goes into the child's stomach or gastrointestinal tract. And every day you have to make sure that tube is patent, is opened, is absolutely in the right place to receive not only the nutrition, but sometimes the dozens of medications. And that requires an ongoing level of self-education, team education, and institutional education. And at Pediatric Specialty Care, we managed to do that.
From admission to discharge, the social workers at Pediatric Specialty Care is with the family every step of the way.
It's a very complex world, and addressing the needs of the family to navigate that world is a responsibility that we take seriously.
From birth to 3, our children receive early intervention services, so they receive physical therapy, speech therapy, occupational therapy, and then service coordination from the community agency. And then up to 3 to 5, they receive additional early intervention services, which includes special instruction or going out to a special needs preschool. And then once our children are school age, we register them with the local district.
So for our school-age children, if they're medically stable, we would enroll them in school and they would be transported to the local and appropriate school. If the kids are not medically stable, we would set up a homebound instruction, so a teacher from the school district would come and see them here at Pediatric Specialty Care.
We're very sensitive to the aesthetics and to the physical environment. We believe it matters. We spend a lot of owners' time examining our work environment and our resident environment to make it as home-like, as efficient, as vibrant as possible.
We celebrate birthdays, any kind of milestones, graduations, or even just a trip to a grocery store. Anything that a child would normally do at home, we try to replicate here. Home reunification is always our goal. We first start with educating the family and getting them trained, so we always require one parent and a backup caregiver are trained so the child can be managed at home safely.
You know that we're starting him on feeding food. Would you like to have her show you?
Parents need to learn their child's care, and so we bring in our nurses, our respiratory therapists, our physical therapists, occupational, speech, social work, to teach the families, teach caregivers the specifics on the medical needs.
Got it! Woohoo! Yay!
Once the family is fully trained, we ask them to do a 24-hour stay. So we set them up in our transition suite, we move the child in with them, and they're required to do all of the care on their own with our nursing staff as standby support. That gives them an opportunity to troubleshoot and to ask questions and find out what it's like overnight. First, they're watching the care being done, then they're assisting, then they're completing it, and then they're repeating that over and over again until we can say, okay, you got this.
Oftentimes what we see happening is children coming out of the most acute settings and getting discharged home, sometimes abruptly, with or without a home care plan in place. What the transitional model allows us to do is allows us, first of all, to buy more time to get the home set up. Our social workers participate with the family in making sure the home has ramp access and has all the clinical tools and technology that's needed in the home to be successful. And also they get to train with all of our staff. If it's a ventilator patient, respiratory training is extremely important. How to suction a patient is extremely important. And those techniques where they work with our clinical team and they get signed off in those core competencies, almost as a new nurse would in orientation. And we work with the family and train them on how to do that. And we feel that continuing to work with the hospital, continuing to work with our physician network, working with the home and with our discharge planners, social workers, and case managers, home all of a sudden becomes ready, safe, and children stay there.
We can't find all of those things in any singular setting, and that is why we created Pediatric Specialty Care.
She gets seen by physicians at least once a week, if not more, and she also receives more time with other children, which she never received when she was at home, and the nursing staff round-the-clock care, as well as more therapy, and that's, I think, helped her improve her health actually overall.
When we talk about need, we're talking about the needs of these children. But there are more needs that need to be taken into consideration. There are the needs of the hospital, their confidence that we can care for these children upon discharge, that we can intervene when necessary so that they won't be readmitted to the hospital. The needs of the physician group who are following these children throughout their progress, where we communicate, share best practices, clinical pathways, policies and procedures, so that they're confident that the child is being cared for properly. And the needs of the family, who are eager and anxious for not only care, but information and guidance.
I'm really grateful for all the help that they've always given to me, especially when it comes to communication, when I either call them or they call me or the social worker stays in contact with me to give me regular updates. So I'm really thankful and really grateful to them.
The best part about my job is taking a child who has no mobility, no head control, unable to sit up, and unable to pretty much move, and then getting them to the point where they're walking, talking, able to run maybe, run to their mom and say mom, and you know, it's just the most, I get goosebumps just telling about it.
When we describe a miracle, it could be that child who manages to swallow a piece of food for the first time, or takes that first step. For these families, that's a miracle.
Good job.